Management of Monochorionic Twin Pregnancy. Green Top Guideline number 51, November 2016. Purpose and Scope. It is recognized that women carrying a monochorionic pregnancy, most commonly twins, may have concerns and anxieties surrounding their pregnancy. This requires accurate information given in a sensitive manner by healthcare professionals and support by a multidisciplinary team, ideally within a multiple pregnancy clinic. Support is also often given in conjunction with the Twins and Multiple Births Association and the Multiple Births Foundation within the UK. Introduction and Background Epidemiology. A monochorionic pregnancy is a multiple pregnancy, most commonly a twin pregnancy, in which babies are dependent on a single shared placenta. Approximately 30% of twin pregnancies in the UK are monochorionic. Monochorionic presentation can also occur in rarer, higher-order multiples, especially triplets, for example, dichorionic or monochorionic triplets. There has been an increase in all types of multiple pregnancies with the increasing use of assisted reproductive technology, socio-demographic changes in our population associated with migration, and deferment of pregnancy to a later maternal age. Assisted reproductive technology increases the prevalence of both dichorionic and monochorionic twinning. However, using day 5 blastocyst transfers seems to have a significantly higher rate of monozygotic twinning compared with cleavage stage day 3 transfers. Monochorionic and dichorionic twin pregnancies have increased risks of preterm birth, fetal growth restriction or FGR, preeclampsia, postpartum hemorrhage, and postnatal complications such as infant feeding difficulties and adverse puerperal mood change. The particular challenges of monochorionic pregnancies arise from the shared placenta and vascular placental anastomosis that are almost universal and connect the fetal circulations of both twins. Specific complications associated with intertwin vascular anastomosis are twin-to-twin transfusion syndrome or TTTS, selective growth restriction or SGR, twin anemia polycythemia sequence or TAPS, twin reverse arterial perfusion or TRAP sequence, and single intrauterine death. Although not exclusive to monochorionic twin pregnancy, it is more common and has global effects on the co-twin. Monochorionic diamniotic or MCDA twin pregnancies carry a higher risk of overall fetal and perinatal loss compared with dichorionic pregnancies. Monochorionic monoamniotic or MCMA pregnancies, where both twins are in a single amniotic sac, 1% of monochorionic twins, carry a very high risk of perinatal loss, most commonly before 24 weeks. Almost all monochorionic placentas contain vascular anastomosis running between the two fetal umbilical cords within and on the surface of the placenta. These connect the fetal circulations. In 80% of cases, these are bidirectional vascular anastomosis, which rarely lead to hemodynamic imbalance between the fetal circulations, but allow a direct vascular connection between the twins with an increased risk of fetal death. In twin-to-twin transfusion syndrome, which complicates up to 15% of monochorionic pregnancies, the placentas have a predominance of unidirectional artery vein anastomosis. This may lead to a hemodynamic imbalance within the circulations of the twins, directly adversely affecting fetal cardiac function, fetoplacental perfusion, but also adversely affecting fetal renal function by discordant activation of the renin-angiotensin axis. Very rarely, twin-to-twin transfusion syndrome complicates MCMA twin pregnancies, as well as both dichorionic and monochorionic triplet pregnancies. Twin anemia polycythemia sequence is an important association in complicated monochorionic pregnancies, especially twin-to-twin transfusion syndrome, occurring in up to 13% of cases post-laser ablation. Significant intrauterine fetal size discordance, difference in estimated fetal weight of greater than 20%, term selective growth restriction or SGR, occurs in up to 15% of monochorionic twins in the absence of twin-to-twin transfusion syndrome and in over 50% of monochorionic twins complicated by twin-to-twin transfusion syndrome. Selective growth restriction or SGR is recognized as a specific monochorionic twin pathological entity associated with a significant differing placental territory between each fetus, interfetal placental anastomosis, and abnormal fetoplacental blood flow. Complications associated with intertwin vascular anastomosis. Diagnosis of monochorionic twin pregnancy. How is monochorionicity diagnosed prenatally, and what is the accuracy of prenatal ultrasound chorionicity allocation? All women with a twin pregnancy should be offered an ultrasound examination between 11 plus 0 weeks and 13 plus 6 weeks of gestation, crown rump length 45 to 84 millimeters, to assess fetal viability, gestational age, and chorionicity, and to exclude major congenital malformations. Chorionicity should be determined at the time the twin pregnancy is detected by ultrasound based upon the number of placental masses, the appearance of the membrane attachment to the placenta, and the membrane thickness. This scan is best performed before 14 weeks of gestation. A photographic or thermal copy record should be taken and placed in the patient's notes, documenting the ultrasound appearance of the membrane attachment to the placenta and an electronic copy stored. If there is uncertainty about the diagnosis of chorionicity, a photographic record of the ultrasound appearance of the membrane attachment to the placenta should be retained and a second opinion should be sought. If there is still doubt in the diagnosis of chorionicity, the woman should be referred to a specialist without delay, as chorionicity is best determined before 14 weeks of gestation. On ultrasound, the fetuses in twin pregnancies should be assigned nomenclature, for example, upper and lower, or left and right, and this should be clearly documented in the woman's case notes to ensure consistency throughout pregnancy. First trimester ultrasound scanning is important in multiple pregnancies as it confirms viability, determines gestational age, defines chorionicity by denoting placental mass numbers and membrane thickness, determines the number of amniotic sacs, and may identify fetal anomalies such as large cystic hygroma and anencephaly. In monochorionic twins, it is also important to exclude a cardiac twinning, which is associated with TRAP, or twin reversed arterial perfusion. At this ultrasound examination, screening for Down syndrome may also be offered to couples. In spontaneously conceived twins, gestational age can be determined at the first trimester scan by using the crown rump length of the larger fetus to avoid the risk of estimating it from a baby with early growth pathology. There is significant benefit in identifying women with monochorionic pregnancies early, as these pregnancies will require additional fetal surveillance. It also allows women to be fully counseled on the risks and appropriate management of monochorionicity to be implemented. Differentiating between monochorionic and dichorionic pregnancies will result in a saving of time and emotional stress by avoiding unnecessary additional interventions in dichorionic pregnancies. Clinicians should be aware that, although ultrasound assessment of chorionicity is very accurate, it does not have 100% sensitivity. Approximately 3% of monochorionic placentas have two placental masses or bilobe placenta, so these are not necessarily dichorionic. Monochorionic twin pregnancies have a single placental mass and a thin intertwin membrane that inserts into the placenta at a perpendicular plane or T-sign. In contrast, dichorionic twin pregnancies have two placental masses or adjacent placental masses forming a lambda sign, as placental tissue is present where the thick intertwin membrane inserts onto the placenta. This assessment should be followed up with noting concordant fetal sacs at the mid-trimester ultrasound scan. It is sometimes necessary to review the assigned chorionicity of multiple pregnancies in the second or even third trimester. A retained photographic record, either in the patient's handheld notes or stored in the hospital notes, will allow this to be easily reviewed. An archived image should also be stored. If it is difficult to determine chorionicity, even after referral, for example, because the woman has booked late in pregnancy, then the pregnancy should be managed as monochorionic until proved otherwise. Accuracy in labeling monochorionic twins is important so that serial growth scan measurements can be consistently applied to the same twin throughout pregnancy, and that any intrauterine or neonatal management can be directed towards the correct twin. Outcome of monochorionic twin pregnancy. What is the outcome of monochorionic compared with dichorionic twin pregnancies? Clinicians and women should be aware that monochorionic twin pregnancies have higher fetal loss rates than dichorionic twin pregnancies, mainly due to second trimester loss, and overall may have a higher risk of associated neurodevelopmental morbidity. This should form part of the parental counseling. Neurological morbidity may be up to 7-fold higher in preterm monochorionic infants compared with dichorionic infants due to associated complications of twin-to-twin transfusion syndrome, selective growth restriction, and single twin death in utero. Optimal screening for chromosomal abnormalities, structural abnormalities, and other fetal complications in monochorionic twin pregnancies. What is the optimal method of screening for chromosomal abnormalities in monochorionic twin pregnancies? Women with monochorionic twins who wish to have aneuploidy screening should be offered nuchal translucency measurements in conjunction with first trimester serum markers, combined screening tests at 11 plus 0 weeks to 13 plus 6 weeks of gestation, crown rump length 45 to 84 millimeters. In women with monochorionic twin pregnancies who miss or who have unsuccessful first trimester screening for aneuploidy, second trimester screening by the quadruple test should be offered. Early data with non-invasive prenatal testing or NIPT are encouraging, but results should be interpreted with caution until larger studies have been carried out. Monochorionic twins are not at increased risk of chromosomal abnormalities over dichorionic twins, but the prevalence of aneuploidy is slightly increased overall in multiple pregnancies because of an indirect association with increased maternal age. First trimester combined screening using nuchal translucency and the serum analytes of free beta-human chorionic gonadotropin and pregnancy-associated plasma protein A, combined test screening, should be offered to pregnant women with monochorionic twins at a crown rump length 45 to 84 millimeters. This screening test has good sensitivity for detecting aneuploidy, 90%, but the false positive rate, up to 10%, is higher than in singletons, 2.5%, and dichorionic twins, 5%. When screening is performed by nuchal translucency, first trimester serum screening, and maternal age, a pregnancy-specific risk is calculated in monochorionic twins. This is in contrast to dichorionic twins, in whom a fetus-specific risk is calculated. Approximately 10% of pregnant women do not have their first antenatal booking appointment in the first trimester. If the gestation at first visit is after 14 weeks, then second trimester serum screening should be offered using the quadruple screen test with an 80% detection rate and a false positive rate of 3% so as to not disadvantage these women. This screening test in monochorionic twins provides a pregnancy-specific risk. Non-invasive prenatal testing or NIPT for fetal trisomy 21 risk assessment is now available and is rapidly replacing other screening tests. In a 2014 meta-analysis, the weighted pool detection rate for trisomy 21 in singleton pregnancies was 99% for a false positive rate of 0.8%. The corresponding values in twin pregnancies were 94.4% and 0%. NIPT in twins versus singletons demonstrated that failed test rates or failure to get a result were higher compared with singletons, 5.6% versus 1.7%. What is the optimum method of screening for structural abnormalities in monochorionic twin pregnancies? All monochorionic twins should undergo a routine detailed ultrasound scan between 18 and 20 plus 6 weeks of gestation, which includes extended views of the fetal heart anatomy as recommended in the Fetal Anomaly Screening Program, Screening of a Singleton Fetus. Structural abnormalities, particularly cardiac abnormalities, are more common in twin and higher order pregnancies than in singleton pregnancies. This is mainly because of the higher incidence of abnormalities in monozygotic twins, owing to the unusual nature of the cleavage of the conceptus compared with dizygotic twins. Monozygotic twins are monochorionic in 70% of cases, hence the higher rates of abnormality in monochorionic twins. Abnormalities specific to monozygotic twins are often midline, such as holoprosencephaly, neural tube defects, and cardiac abnormalities. As one cannot determine monozygosity using ultrasound, both monochorionic and dichorionic twins have the same recommended second trimester ultrasound screening regimen, which is in line with the National Institute for Health and Care Excellence Guideline. The management of monochorionic pregnancies, where one fetus has a congenital abnormality, is complex because of shared circulations within the placenta. Timely diagnosis facilitates management by allowing time to prepare, optimization of fetal surveillance depending on the anomaly, involvement of multidisciplinary specialists, for example, genetics team, pediatric cardiologists, and pediatric surgeons, and appropriate birth planning, place, timing, and mode, including access to intrauterine management where it is possible. Selective termination of a single fetus in a monochorionic pregnancy should be assessed and carried out in a center with expertise and experience in performing such prenatal procedures. In addition, increased prenatal surveillance, the potential for referral to a tertiary specialist center, and the adverse risk to the pregnancy must be discussed in a timely fashion. What is the optimum ultrasound regimen for monochorionic twin pregnancies? Fetal ultrasound assessment should take place every 2 weeks in uncomplicated monochorionic pregnancies from 16 plus 0 weeks onwards until delivery. At every ultrasound examination, liquor volume in each of the amniotic sacs should be assessed and a deepest vertical packet or DVP depth measured and recorded, as well as the umbilical artery pulsatility index or UAPI. Fetal bladders should also be visualized. Although first presentation of twin-to-twin transfusion syndrome is rare, after 26 plus 0 weeks of gestation, it can occur and therefore scans should be performed at 2 weekly intervals in uncomplicated monochorionic twins until delivery. From 16 plus 0 weeks of gestation, fetal biometry should be used to calculate an estimated fetal weight and the difference in estimated fetal weight calculated and documented. As the risk of selective growth restriction extends to delivery, this should be performed at 2 weekly intervals until delivery. There are a number of serious pathologies in monochorionic twin pregnancy that need to be screened for routinely. Ultrasound is required to make this diagnosis, and therefore, serial ultrasound is required at regular intervals. Ultrasound examinations between 16 and 26 weeks of gestation focus primarily on the detection of twin-to-twin transfusion syndrome. After 26 weeks, the main purpose is to detect selective growth restriction or concordant growth restriction, and more rarely, twin anemia polycythemia sequence or late onset twin-to-twin transfusion syndrome. This ultrasound screening should include, as a minimum, fetal biometry measurements, head, abdominal, and femur measurements, measurement and recording of deepest vertical packet depth of both sacs, and evaluation of fetal bladders, for example, size and visibility. From 16 to 0 weeks of gestation, estimated fetal weight should be calculated and documented. In addition, if at any point in time there is evidence of significant growth discordance or a suspicion of twin-to-twin transfusion syndrome, then umbilical artery pulsatility index or UAPI, middle cerebral artery peak systolic velocity or MCA-PSV, and pulsatility index and ductus venosus Dopplers should be performed. From 16 weeks of gestation, umbilical artery Doppler velocities should be evaluated and the presentation of positive, absent, or reverse velocities noted and documented. From 20 weeks of gestation, UAPI should be performed even in the absence of signs of twin-to-twin transfusion syndrome or growth discordance, uncomplicated monochorionic twins, and plotted on standard charts. This may be best performed in a multiple pregnancy clinic. What are the optimal methods of screening for specific complications of monochorionic twin pregnancies? Screening for twin-to-twin transfusion syndrome. Screening for twin-to-twin transfusion syndrome by first trimester, nuchal translucency measurements should not be offered. Women with monochorionic twin pregnancies should be asked to report sudden increases in abdominal size or breathlessness to healthcare professionals in their secondary or tertiary centers, as this may be a manifestation of twin-to-twin transfusion syndrome. Screening for twin-to-twin transfusion syndrome should be by ultrasound examination from 16 to 0 weeks onwards at 2 weekly intervals, noting and recording fetal biometry and liquor volumes, deepest vertical packet. Fetal bladders should also be visualized. Unfortunately, common symptoms of twin pregnancy overlap with those associated with pathological conditions such as twin-to-twin transfusion syndrome. Pregnant women with monochorionic twins should have a low threshold for presenting to healthcare professionals with concerns. This should be discussed by healthcare professionals at their first booking visit. The ultrasound diagnosis of twin-to-twin transfusion syndrome is based on the following criteria. Significant amniotic fluid discordance. This is the key to the diagnosis. There must be oligohydramnios with DVP less than 2 cm in one sac, the donor, and polyhydramnios in the other sac, DVP more than 8 cm before 20 weeks of gestation and more than 10 centimeters after 20 weeks of gestation, the recipient. Discordant bladder appearances with no urine in the donor fetal bladder in severe twin-to-twin transfusion syndrome presenting before 26 weeks of gestation. Hemodynamic and cardiac compromise both in the recipient and/or donor twins. If there is a liquor volume discordance in monochorionic twins that does not reach the threshold for the diagnosis of twin-to-twin transfusion syndrome, management should be individualized with a high degree of vigilance. Screening for twin anemia polycythemia sequence. Twin anemia polycythemia sequence, or TAPS, should be screened for following fetoscopic laser ablation for twin-to-twin transfusion syndrome and in other complicated monochorionic pregnancies requiring referral to a fetal medicine center, such as those complicated by selective growth restriction by serial MCA-PSV. Twin anemia polycythemia sequence is a form of twin-to-twin transfusion syndrome characterized by a significant discordance in hemoglobin level between twins without significant amniotic fluid discordance. This can be diagnosed by the presence of increased MCA-PSV in the donor, suggestive of fetal anemia, greater than 1.5 multiples of the normal median, and a decreased MCA-PSV in the recipient twin, suggestive of polycythemia, less than 1.0 multiples of the normal median, with the absence of significant oligohydramnios and/or polyhydramnios sequence. TAPS may occur spontaneously in up to 2% of monochorionic twins and in up to 13% following fetoscopic laser for twin-to-twin transfusion syndrome. The placentas in monochorionic pregnancies complicated by TAPS are characterized by the presence of only a few minuscule artery-vein vascular anastomosis. These small anastomoses allow a slow transfusion of blood from the donor to the recipient, leading progressively to a significant discordance in hemoglobin levels. The absence of severe amniotic fluid discordances in TAPS may be related to the very slow intertwin blood transfusion, allowing more time for hemodynamic compensatory mechanisms to take place. Because twin anemia polycythemia sequence mainly occurs in complicated cases, And because there is little evidence to guide management, screening of monochorionic twins for TAPS using serial MCA-PSV measurements is not routine and should be confined to complicated monochorionic twin pregnancy where the risk of TAPS is high, those with twin-to-twin transfusion syndrome or selective growth restriction. Postnatal diagnosis of twin anemia polycythemia sequence is based on the presence of chronic anemia in the donor, including reticulocytosis and polycythemia in the recipient. Postnatal hematological criteria include an intertwin hemoglobin difference greater than 80 grams per liter and a reticulocyte count ratio greater than 1.7. Screening for SGR or selective growth restriction. At each scan from 20 weeks of gestation at 2 weekly intervals onwards, calculate estimated fetal weight discordance using 2 or more biometric parameters. Calculate percentage estimated fetal weight discordance using the following formula: larger twin EFW minus smaller twin EFW divided by larger twin EFW multiplied by 100. Liquor volumes as deepest vertical packet should be measured and recorded to differentiate from twin-to-twin transfusion syndrome. An EFW discordance of greater than 20% is associated with an increase in perinatal risk. Such pregnancies should be referred for assessment and management in fetal medicine units with recognized relevant expertise. Umbilical artery Doppler evaluation in monochorionic twins with selective growth restriction allows definition of prognosis and potential morbidity. In particular, those with absent or reversed end diastolic velocities and cyclical umbilical artery Doppler waveforms, intermittent AREDV or IA-REDV, are at increased risk of perinatal mortality and morbidity. Unequal placental sharing and marginal or filamentous cord insertions are common in monochorionic twins and can result in discordant fetal growth, where one fetus is usually normal size and the other small for gestational age, defined as estimated fetal weight less than the 10th centile. However, even if both fetuses have an estimated fetal weight greater than the 10th centile, there may be significant size discordance. This is termed selective growth restriction. Selective growth restriction, or SGR, is encountered in approximately 10 to 15% of all monochorionic multiple pregnancies. The prospective diagnosis initially may be difficult as there may be diagnostic overlap between mild twin-to-twin transfusion syndrome and selective growth restriction. Amniotic liquor volumes, DVP, in twin-to-twin transfusion syndrome may differ between the fetuses because of polyhydramnios in one of the amniotic sacs and oligohydramnios in the other amniotic sac, but SGR may also be present. However, in isolated SGR, this will differ as there is commonly oligohydramnios in one of the amniotic sacs and normal liquor in the other amniotic sac. Poor in utero growth of both twins may reflect multifactorial causes such as maternal factors resulting in global uteroplacental dysfunction, whereas discordant twin growth may be attributed to differences in genetic potential between co-twins, placental dysfunction confined to one placenta only, or one placental territory within a shared placenta. In addition, twin-to-twin transfusion syndrome represents a distinct entity of which discordant growth is a common feature. Discordant growth is recognized as an independent risk factor for adverse perinatal outcome in monochorionic twins and is associated with a substantial increase in perinatal mortality and morbidity for both twins. Calculated difference in estimated fetal weight is a sensitive method of defining SGR and appears to be linked with adverse outcome when this is significantly different. Umbilical artery waveforms in monochorionic twins with selective growth restriction may reflect adverse prognosis for the pregnancy. For this reason, the guideline recommends that umbilical artery Doppler pulsatility index measurements are taken from 20 weeks of gestation and plotted on gestational nomogram charts, with umbilical artery Doppler velocities noted to have positive or AREDV from 16 weeks. Doppler waveforms may demonstrate positive diastolic velocities type 1, AREDV type 2, or cyclical diastolic waveforms type 3 with an attendant worsening of prognosis for perinatal mortality and morbidity. IAREDV on umbilical artery Doppler velocity assessment are more common in MCDA SGR 45% than uncomplicated pregnancies 5% or those complicated by severe twin-to-twin transfusion syndrome 2%. This condition appears to result from large artery-to-artery anastomosis. Selective growth restriction type 1 is associated with a relatively good outcome, more than 90% of perinatal survival. Type 2 selective growth restriction is associated with a high risk, up to 29%, of intrauterine demise of the growth-restricted twin and/or preterm delivery. Type 3 selective growth restriction is associated with a 10 to 20% risk of unexpected fetal demise of the smaller twin, even if stable ultrasound features and/or normal computerized cardiotocography hours or days before, and a 10 to 20% risk of neurological injury in the larger twin. Management of complex pathologies associated with a monochorionic twin pregnancy. The management of twin-to-twin transfusion syndrome. How useful are grading systems for severity of twin-to-twin transfusion syndrome in establishing prognosis? At diagnosis, twin-to-twin transfusion syndrome should be staged using the Quintero system. In addition, measurement of umbilical artery Doppler velocities, MCA-PSV, and ductus venosus Doppler studies should be performed and documented. The Quintero system of staging twin-to-twin transfusion syndrome has some prognostic value, but the course of the condition is unpredictable and may involve improvement or rapid deterioration within a short time span. Amniotic fluid discordance without fulfilling the 8 cm and/or 2 cm criteria, for example, within the normal range, together with normal umbilical artery Doppler velocimetry, is associated with good outcome, 93% overall survival, and low risks of progression to severe twin-to-twin transfusion syndrome of 14%. There is controversy about Quintero's staging of twin-to-twin transfusion syndrome since stage 1 disease may not necessarily be associated with the best outcome, and indeed, recipient twins within stage 1 twin-to-twin transfusion syndrome may have evidence of cardiac dysfunction. What is or what are the optimal treatment or treatments of twin-to-twin transfusion syndrome and their outcomes? Twin-to-twin transfusion syndrome should be managed in conjunction with fetal medicine centers with recourse to specialist expertise and treatment in super-regional centers. Twin-to-twin transfusion syndrome presenting before 26 weeks of gestation should be treated by fetoscopic laser ablation rather than amnioreduction or septostomy. There is evidence that fetoscopic laser ablative method should be the Solomon technique. Centers performing fetoscopic laser ablation should perform at least 15 procedures per year, rolling 3-year average. Weekly ultrasound assessment, including examination of the fetal brain, heart and limbs, and serial measurements of UAPI, MCAPSV, and ductus venosus Doppler velocities should be performed. After 2 weeks post-treatment, the ultrasound interval can be increased to every 2 weeks, noting UAPI, MCAPSV, and DVP with documentation of adequate fetal growth by calculating estimated fetal weight. In treated twin-to-twin transfusion pregnancies, ultrasound examination of the fetal heart should be performed by the fetal medicine specialist to exclude functional heart anomalies. There are super-regional centers in the UK that will offer fetoscopic laser ablation for twin-to-twin transfusion syndrome. Each case should be managed on an individual basis, but commonly, this treatment is for Quintero stage 2 or more, and many will treat this condition if there is Quintero stage 1 with significant polyhydramnios, 8 cm or more, or cervical shortening less than 25 millimeters. The conclusion of the Cochrane review was that endoscopic laser coagulation of anastomotic vessels should continue to be considered in the treatment of all stages of twin-to-twin transfusion syndrome to improve neurodevelopmental outcomes in the child. When compared with amnioreduction, treatment with laser coagulation does not appear to increase or reduce the risk of overall death, stillbirth, neonatal and postneonatal in this condition, but it appears to result in more children being alive without neurological abnormality. Amnioreduction can be retained as a treatment option for those situations where the expertise for laser coagulation is not available, pending transfer to a unit where such treatment can be obtained, or when the condition is diagnosed after 26 weeks of pregnancy. However, this may complicate future treatment if associated with inadvertent septostomy. There is evidence that fetoscopic laser ablation is the best treatment of twin-to-twin transfusion syndrome in early onset disease less than 17 weeks and late onset disease after 26 weeks. Anastomosis may be missed at fetoscopic laser ablation, and this is the most common cause of recurrence and morbidity. Recurrent twin-to-twin transfusion syndrome can occur in up to 14% of pregnancies treated with fetoscopic laser ablation and be associated with or without twin anemia polycythemia sequence. Such outcomes are associated with a worsening of neonatal morbidity. There is randomized controlled trial evidence that modification of the primary fetoscopic laser technique by equatorial laser dichorionization or the Solomon technique significantly reduces these complications of recurrent twin-to-twin transfusion syndrome and twin anemia polycythemia sequence. Fetoscopic laser ablation can be performed in monochorionic and dichorionic triamniotic triplet pregnancies, but the placental angioarchitecture is usually more complex and the perinatal outcomes are in general poorer than in the treatment of twins. Some women request termination of pregnancy when severe twin-to-twin transfusion syndrome is diagnosed, and this should be discussed as an option. Another option is to offer selective termination of pregnancy using bipolar diathermy of one of the umbilical cords or using radiofrequency ablation with inevitable sacrifice of that baby. This may be appropriate, for example, if there is evidence of cerebral damage in either twin. Most experts advocate that ultrasound examination with brain imaging, fetal measurement, and Doppler assessment, especially of the MCA-PSV, should be performed every week for the first 2 weeks and then every other week following clinical resolution. Twin anemia polycythemia sequence may complicate post-fetoscopic laser ablation in up to 13% of cases, the most common complication after fetal demise. Therefore, at these ultrasound examinations, MCA-PSV should be performed and the result recorded. When should the delivery of monochorionic twin pregnancies complicated by twin-to-twin transfusion syndrome take place? Delivery of monochorionic twin pregnancies previously complicated by twin-to-twin transfusion syndrome and treated should be between 34 plus 0 and 36 plus 6 weeks of gestation. Even after successful treatment, regular ultrasound surveillance should be routine. Consideration should be given to delivery of the surviving twin or twins between 34 plus 0 and 36 plus 6 weeks or earlier if there are concerns. Prophylactic maternal steroids should be given if possible prior to delivery. Mode of delivery can be individualized, but often this is by cesarean section. The management of selective growth restriction. Selective growth restriction, or SGR, in monochorionic twins requires evaluation in a fetal medicine center with expertise in the management of such pregnancies. In cases of early onset SGR, in association with poor fetal growth velocity and abnormal umbilical artery Doppler assessments, selective reduction may be considered an option. In SGR, surveillance of fetal growth should be undertaken at least every 2 weeks with fetal Doppler assessment by umbilical artery and middle cerebral artery pulsatility index and peak systolic velocity. If umbilical artery Doppler velocities are abnormal, the Doppler assessments should be undertaken in line with national guidance, measuring ductus venosus waveforms. Clinicians should be aware that there is a longer latency period between diagnosis and delivery in monochorionic twins complicated by SGR compared with growth restriction in dichorionic twin pregnancy or singleton pregnancy. Abnormal ductus venosus Doppler waveforms, reverse flow during atrial contraction, or computerized CTG short-term variation should trigger consideration of delivery. In type 1 SGR, planned delivery should be considered by 34 to 36 weeks of gestation if there is satisfactory fetal growth velocity and normal umbilical artery Doppler waveforms. In type 2 and type 3 SGR, delivery should be planned by 32 weeks of gestation unless fetal growth velocity is significantly abnormal or there is worsening of the fetal Doppler assessment. It is important to prospectively inform parents that in selective growth restriction and twin-to-twin transfusion syndrome, even after apparently successful treatment, there can be acute transfusional events which are neither predictable nor preventable, and therefore, despite regular monitoring, there may still be adverse perinatal outcomes. Once there is a suspicion of SGR or the diagnosis has been prospectively made using ultrasound, the pregnancy should be managed in conjunction with a regional fetal medicine center with specialist expertise in managing this condition. There is a need to measure amniotic sac Likert volumes and to assess Doppler velocities within the fetal arterial and venous circulations. Umbilical artery Doppler evaluation in monochorionic twins with selective growth restriction allows the prospective definition of 3 subtypes, and the consequences are dependent upon this evaluation and gestational age. Prior to viability, 24 weeks, if the small twin has a significantly reduced fetal growth velocity, change in measured abdominal circumference of less than 1 st over 14 days, in the presence of umbilical artery Doppler abnormalities, there is a significant risk of single fetal demise. In such circumstances, to protect the appropriately grown co-twin, selective termination of pregnancy using vaso-occlusive techniques such as bipolar cord occlusion or radiofrequency ablation may be considered. This should be assessed and performed in a tertiary center with expertise. Again, informed but sensitive discussion with patients is mandatory. There is limited evidence to guide clinical care in these complex cases. However, there is international consensus that such monochorionic twin pregnancies require regular review with interval ultrasound biometry to monitor fetal growth velocity and placental and fetal circulation assessment by umbilical artery, middle cerebral artery, and ductus venosus Doppler waveform measurements. The aim is to prolong pregnancy to at least viability and to achieve appropriate gestation for delivery, 32 to 34 weeks, but to avoid the complication of single fetal death and the consequences for the surviving fetus. Timing of delivery, less than 32 weeks of gestation, is dependent upon assessment by computerized CTG and or ductus venosus waveform velocimetry. For monochorionic twin SGR, where there is umbilical Doppler abnormality, delivery should be undertaken at 32 weeks, in line with singleton FGR with AREDV. The placental anastomosis in monochorionic twins paradoxically may be beneficial for the smaller twin, as transfusion from the larger twin may compensate for the placental insufficiency, thus interfering with the natural history in comparison with singleton and dichorionic twin pregnancies. This is also associated with the presence of artery-to-artery anastomosis. This prolongs survival in the growth-restricted fetus, resulting in a longer latency period to deterioration and delivery, up to 10 weeks versus 3 to 4 weeks from diagnosis of FGR. In monochorionic twins, where the placental vascular anastomosis remain intact, there is a risk of acute intertwin transfusional events causing fetal death and morbidity in the form of neurological morbidity. This is true of apparently uncomplicated monochorionic twins, but more prevalent in monochorionic twins complicated by selective growth restriction and even treated twin-to-twin transfusion syndrome. Management of twin anemia polycythemia sequence or TAPS. Clinicians should be aware that the natural history, fetal and neonatal implications, and optimal treatment and/or surveillance of monochorionic pregnancies diagnosed with twin anemia polycythemia sequence are poorly established. Fetoscopic laser ablation for the treatment of twin-to-twin transfusion syndrome using the Solomon technique significantly reduces the risk of recurrent disease and twin anemia polycythemia sequence. The optimal management of TAPS once it occurs is not clear from the literature, but possible options include expectant management, delivery, intrauterine blood transfusion, intravenous and/or intraperitoneal, with or without partial exchange transfusion, selective feticide, or fetoscopic laser surgery. Fetoscopic laser surgery is the only treatment for the cause of this disease, in analogy with twin-to-twin transfusion syndrome, but is technically challenging due to the absence of polyhydramnios and the presence of only minuscule anastomosis. If detected prenatally, management options need to be individualized and uncertainty discussed with the parents. Perinatal outcome in twin anemia polycythemia sequence appears to vary according to the severity. Outcome may range from double intrauterine fetal demise to the birth of 2 healthy neonates with a significant intertwin hemoglobin discordance. Neonatal morbidity in TAPS appears to be mainly limited to hematological problems at birth. Donor twins may be severely anemic and require blood transfusions, whereas recipient twins may be severely polycythemic and require partial exchange transfusion. The management of monochorionic twin pregnancies complicated by single twin demise. What are the consequences for the surviving twin after fetal death of the co-twin in a monochorionic pregnancy, and what is optimal clinical management? Clinicians should be aware that monochorionic pregnancies not complicated by twin-to-twin transfusion syndrome, selective growth restriction, or twin anemia polycythemia sequence are still at risk of fetal death and neurological abnormality. After a single fetal death in a monochorionic pregnancy, clinicians should be aware that the risk to the surviving twin of death or neurological abnormality are of the order of 15% and 26% respectively. Single fetal death in a monochorionic pregnancy should be referred and assessed in a fetal medicine center with multidisciplinary expertise to manage these cases. Fetal magnetic resonance imaging or MRI of the brain may be performed 4 weeks after co-twin demise to detect neurological morbidity if this information would be of value in planning management. In monochorionic twins, where the placental vascular anastomosis remain intact, there is a risk of acute intertwin transfusional events causing fetal death and morbidity in the form of neurological morbidity. This is true of apparently uncomplicated monochorionic twins, but more prevalent in monochorionic twins complicated by selective growth restriction and even treated twin-to-twin transfusion syndrome. Damage to the surviving monochorionic twin after the death of its co-twin is believed to be caused by acute hemodynamic changes around the time of death, with the survivor losing part of its circulating volume into the circulation of the dying twin. This may cause transient or persistent hypotension and low perfusion, leading to the risk of ischemic organ damage, notably but not exclusively to the watershed areas of the brain. Clinical management is complex and should be overseen by fetal medicine experts with the knowledge and experience to advise parents about the advantages and disadvantages of different approaches. Rapid delivery is usually unwise unless at term, as fetal brain injury of the surviving twin occurs at the time of demise of the co-twin. Therefore, immediate delivery only adds prematurity to the possible hypotensive cerebral injury the surviving twin may have already sustained. Serious compromise of the surviving fetus may be anticipated, and this should be discussed with parents, including the significant risk of long-term morbidity. Evidence of fetal compromise, such as significant cardiotocographic abnormality and/or evidence of anemia in the survivor if a single fetal death occurs late in pregnancy, could represent continuing and/or established damage to the brain. A conservative management policy is often appropriate with serial fetal brain ultrasound imaging and a fetal cranial MRI scan planned, commonly 4 weeks after the sentinel event. The appearances of intracranial neurological morbidity on ultrasound are variable and may take up to 4 weeks to develop. Fetal MRI provides earlier and more detailed information about brain lesions, hemorrhagic or ischemic, in the surviving fetus than ultrasound, and its use should be considered. In cases of single intrauterine demise with MRI or ultrasound findings of neurological morbidity, late termination of pregnancy would be an option. The gestational age at the time of diagnosis is relevant, and the views of the parents will be of paramount importance. How should fetal anemia be monitored after single twin intrauterine death? Fetal anemia may be assessed by measurement of the fetal MCA-PSV using Doppler ultrasonography. In monochorionic pregnancies complicated by single fetal death, there was a strong correlation between fetal anemia, assessed by chordocentesis, and fetal MCA-PSV. The presence of an increased MCA-PSV in the surviving twin would suggest fetal anemia and, therefore, a significant inter-twin transfusion. This would increase the risk of hypotensive neurological injury and thus would be helpful information in the counseling of parents and timing of fetal brain MRI. Treatment by intrauterine transfusion is controversial as this may improve fetal survival without reducing the long-term risk of neurological morbidity. Timing and mode of delivery in uncomplicated monochorionic pregnancies. What is the optimal timing and method of delivery for otherwise uncomplicated monochorionic pregnancies without twin-to-twin transfusion syndrome, selective growth restriction, or twin anemia polycythemia sequence? Women with monochorionic twins should have timing of birth discussed and be offered elective delivery from 36 plus 0 weeks with the administration of antenatal steroids unless there is an indication to deliver earlier. It is appropriate to aim for vaginal birth of MCDA twins unless there are other specific clinical indications for cesarean section. For uncomplicated monochorionic pregnancies, there may be a higher risk of unexplained fetal demise despite intensive fetal surveillance. The majority, 58% of women with uncomplicated twin pregnancies, give birth spontaneously before 37 plus 0 weeks. As with all pregnancies, parental views will also be important in reaching a conclusion about the best individualized method of monochorionic twin delivery, including opting for cesarean section. In addition to the complexities of twin delivery, for example, malpresentation, there is a small risk of acute feto-fetal transfusional events during labor, and this is one of the reasons why continuous electronic fetal monitoring during labor is recommended. Monochorionic, monoamniotic, or MCMA pregnancies. What are the specific problems of MCMA pregnancies and how should they be managed? Monochorionic, monoamniotic twins almost always have umbilical cord entanglement when visualized using color flow Doppler. Such a finding has not consistently been demonstrated to contribute to overall morbidity and mortality. MCMA twins have a high risk of fetal death and should be delivered by cesarean section between 32 plus 0 and 34 plus 0 weeks. Higher order multiple pregnancies with reference to monochorionicity. What is the outcome of monochorionic and dichorionic compared with trichorionic triplet pregnancies? Clinicians should be aware that monochorionic, dichorionic triplet pregnancies have higher fetal loss rates than trichorionic triplet pregnancies and may be complicated by feto-fetal transfusion syndrome, selective growth restriction, and twin anemia polycythemia sequence. Selective reduction should be discussed in all higher-order pregnancies, including triplets. Increased ultrasound surveillance is warranted in a fetal medicine center with expertise to manage such cases. Discordant abnormalities in monochorionic pregnancies. What is the incidence of and the therapeutic options for discordant abnormalities in monochorionic pregnancies, including twin reverse arterial perfusion sequence? Monochorionic twins that are discordant for fetal anomaly must be referred promptly for assessment and counseling in a fetal medicine center with consideration for treatment. Karyotyping of monochorionic twins should be managed in a fetal medicine center. Meticulous mapping of the position of the twins within the uterus should be performed both at the time of prenatal diagnostic tests and invasive treatments. During amniocentesis, both amniotic sacs should be sampled in monochorionic twin pregnancies unless monochorionicity is confirmed before 14 weeks and the fetuses appear concordant for growth and anatomy. Prior to invasive testing or in the context of twins discordant for an abnormality, selective reduction should be discussed and made available to those requesting the procedure after appropriate counseling. Monitoring for disseminated intravascular coagulopathy is not indicated in monochorionic twin pregnancies undergoing selective reduction. Selective feticide by intravascular injection of an abortifacient is not an option in monochorionic pregnancies because of the presence of placental anastomosis. The potential risks of intrafetal and/or umbilical cord ablative procedures should be discussed prospectively, including the risk of co-twin loss and urological morbidity. Documentation and discussion of heterokaryotypic monozygotic karyotypic abnormalities should take place. A higher rate of structural anomalies is observed in twins compared with singletons. Approximately 1 to 2% of twin pregnancies face the dilemma of expectant management versus selective termination following diagnosis of an anomaly affecting only one fetus. Structural anomalies in monochorionic pregnancies are twice that expected in dichorionic pairs given the monozygosity. Detailed ultrasound assessment, fetal karyotyping, and a discussion of prognosis is required with reference both to the abnormal and normal twin. Selective termination in a monochorionic pregnancy is an option, but as the fetal circulations are not independent, it cannot be performed with injection of medical therapeutics because of the effect on the co-twin. More invasive and higher risk procedures such as cord coagulation and intrafetal ablative procedures such as radiofrequency ablation are necessary to induce termination of one twin without causing morbidity or death in its co-twin. It is essential that at the time of prenatal diagnostic tests, the pregnancy is mapped carefully, noting the position and site of the fetuses in relation to the placenta and amniotic sac, and documented. This is ideally performed by the operator who would perform the technique of selective termination of pregnancy if required. It is mandatory to discuss selective termination of pregnancy and complicating factors in monochorionic twins, including the potential risk to the normal twin. Preterm rupture of membranes, 10 to 15%, and chorioamnionitis remain significant complications. Monochorionic twins complicated with an acardiac twin and twin reverse arterial perfusion sequence do not always require invasive treatment. Selection for treatment appears to be dependent on the relative size of the acardiac twin to the pump twin. The larger the acardiac twin, the greater the risk and the need for therapy, and the presence of any cardiovascular impairment in the pump twin. If treatment is considered, then there is some evidence that treatment should take place before 16 weeks of gestation, but evidence is not strong, and it should be performed in centers with expertise in such treatment modalities. Careful monitoring and ultrasound surveillance are required. Rarely, monozygous twins can have different chromosome makeups. This is known as heterokaryotypic monozygous twinning. When anomalies are identified in the first or early second trimester in one of a monochorionic twin pair, which may be markers of aneuploidy, a discussion should take place as to the merits and risks of chorionic villus sampling versus waiting for a double amniocentesis at 15 to 16 weeks when both sacs are sampled and the individual karyotype of each twin can be determined with certainty. Conjoined twins. How are conjoined twins diagnosed and what are the outcomes? Conjoined twins are exceedingly rare and prenatal assessment is required in a tertiary fetal medicine center so that diagnosis can be confirmed and prognosis discussed in conjunction with a multidisciplinary team. Conjoined twins are very rare and by definition are monochorionic monoamniotic twin pregnancies. The prevalence is 1 in 90,000 to 100,000 pregnancies. Such MCMA twins are complex and require careful detailed expert ultrasound imaging, usually including MRI, and multidisciplinary discussion. Most cases are now prenatally diagnosed and delivered by elective cesarean section, but vaginal deliveries of conjoined twins are reported. Risk of dystocia and uterine rupture has been reported in association with cases and diagnosed prenatally. Prenatal diagnosis of conjoined twins with ultrasound is now well reported from the first trimester, with detailed assessment of cardiovascular anatomy, important for determining prognosis and planning management. What are the training competencies required for managing monochorionic pregnancies? All sonographers who undertake routine ultrasound scans during pregnancy must be trained to establish chorionicity and the correct labeling of twins. All sonographers who undertake mid-trimester, 18 plus 0 to 20 plus 6 weeks, And fetal growth scans of monochorionic twins should be made aware of the appearances of twin-to-twin transfusion syndrome, selective growth restriction, and twin anemia polycythemia sequence, and the need to refer patients onto specialist centers if such features present. Fetal medicine centers undertaking fetal therapy for relatively rare complications of monochorionic twins should have a minimum of 2 experienced operators and more than 15 cases per year, rolling 3-year average to maximize perinatal outcomes and minimize long-term morbidity.